One of the innovations that we're most proud of here at Mount Sinai St. Luke's is the creation of our Daily Management Center. Our Daily Management Center is essentially a command center, but it's more than that. So when you enter the Daily Management Center, what you see are 9 or 10 tiles, flat tiles up on a screen with a number of different data points from throughout the hospital. Throughput data, operating room data, safety and quality data, discharge data, transition of care data, population health data, you name it, in some form or fashion, we actually have it up on these various screens. But it's not random data that appear on these screens, but it's been very carefully curated and cultivated data, which we believe help to give us the greatest insight into the way our hospital is running, and an insight that is in real time, and that's the difference. I'll give you an example that my director of my Lean Lab uses when she talks about the Daily Management Center. You know, she gives an example of when you're driving a car, and she says, you know, when you look at your speedometer, what does your speedometer tell you? Your speedometer tells you the speed at which you're driving right then and there. It doesn't tell you the speed at which you're driving 4 hours ago, or 8 hours ago, or 12 hours ago, or a week ago, or a month ago. But as hospital executives, that's the kind of data we're used to. We're used to data that in some form or fashion lags. It could lag a few hours, it could lag a few days, it could lag a month, it could lag several months. Data that lag are not useful from an operating standpoint. What we need are data that we are seeing in real time that give us the ability to make operational decisions with the best available information in order to be able to allocate our scarce resources most effectively and efficiently. So I'll give you a couple of examples of how we've used our Daily Management Center. So our Daily Management Center will tell us, for example, how many patients at any particular time are in the emergency department, which is fantastic information to have, but it'll go a step further. Our Daily Management Center will highlight how many patients who are 85 years or older who are in our emergency department who have been admitted but don't yet have a bed. That's a lot. Why do we care about that? Well, these are patients who are 85 and older, which means they're frail elderly, and they're in the emergency department but admitted, which means that the emergency department staff is paying more attention to the new patients that are coming in than the patients for whom a disposition has already happened. So what do? Well, we've developed, using our lean tools and techniques and principles, we've developed standard work for that particular type of patient. So what does the standard work include? Well, it includes the following. One, we send a bed down as opposed to a stretcher for the patient who's 85 years or older. Why do we do that? Well, we do that because we want to avoid that patient developing some sort of a pressure ulcer. The wound care nurse goes down to the emergency room to pay a visit to that 85-year-old or older patient. We prioritize that patient for getting a bed up on the inpatient units. So those are just three examples of the standard work that we've developed for that particular patient in order to be able to protect that patient from obtaining a pressure ulcer or in some other way decompensating while in the hospital awaiting a bed up on a unit. Visibility into how many patients in real time fit that criteria is what allows us to be able to do that. Another example, we know in real time how many patients are on telemetry in a telemetry bed for more than 72 hours. Why does that matter? Because if a patient's been on telemetry for more than 72 hours, it's reasonable to ask whether the telemetry order can be discontinued by a physician. Telemetry beds are always scarce in a hospital. There's always less telemetry beds than there is demand for telemetry beds. So it's critically important to be able to safely move patients from telemetry to a general med surg bed that is not telemetry enabled as quickly as is reasonable and is safe. Again, by flagging when patients have been in a telemetry bed for over 72 hours, it allows us to ask the question of the physicians so that the physicians can make an informed determination about whether the patient should still be there or could go to a general med surg bed. We're able to, in real time, be able to provide our emergency managers with up-to-date, accurate information about what bed capacity we have if there's a real need to be transferring patients from one facility within the system to another due to some sort of emergency, or from one other hospital outside the system to our particular hospital, again, if emergency conditions or a situation demand it. We're gonna move over time from having this sort of information be made available to us. And by the way, all of this information that I just described comes out of our electronic medical records system. And the reason we think that's important is that we believe it's critical, particularly given the amount of money that we spend on installing electronic medical record systems at hospitals across the country. We think it's critically important to maximize the value of the return on the dollars that we've invested. And one of the ways to do that is to not only use the electronic medical record for clinical purposes, but we also want to use it for operating purposes. And I just gave you two examples of how we use it to help our operations. I'll give you a third. A third example would be we're able to identify patients that come to our emergency department who are at risk for a 30-day readmission as a heart failure patient. So in other words, they've come to our hospital, they've been diagnosed with heart failure, they've left, now they've come back to our emergency department, and we can flag them right away. Why does that matter? We've developed standard work so that we intervene with that patient to avoid a readmission, to direct that patient elsewhere, either to observation, to their physician's office, or to some community support as needed. But what we try to do in that instance is not admit the patient, again, unless it's absolutely clinically warranted and there's no other option. But the data, the real-time data, afford us the ability to be able to make the intervention and potentially avoid the readmission. Now, we want to move beyond this sort of descriptive data that comes out of electronic medical record system and move to the next generation of information, which would be really out of predictive analytics. And we're proud here at Mount Sinai to have a terrific cadre of data scientists, and our data scientists are working day and night to perfect a series of predictive analytic models for clinical conditions that once they've perfected them, or they're comfortable that the models are accurately predictive of clinical behavior in the Mount Sinai Health System, we'll move those models from being beta tested or tested in the background to actually going live in our command center, and we'll use those predictive models to, again, be able to deploy our assets, our staff, our resources, to be able to optimize our ability to deliver care to our patients. We have predictive models regarding delirium. We have predictive models relative to malnutrition. We have predictive models that help us to understand whether a patient is likely to decompensate within the ICU over a period of time. Just as some examples. As those models get perfected, those models will move from testing environment to our command center. We'll see that information in our command center tiles, and we'll be able to make decisions, operating decisions, clinical decisions accordingly. So what we think is really important about our command center or daily management center is it's not kind of the traditional command center, which is all about the flow of patients between facilities, or it's really about a glorified bedboard. This is much more than that. This is about clinical operations. This is looking at descriptive clinical operational data. This is looking at prescriptive clinical operational data as well, and allowing us to optimize our decision making, and to do so in a way that's joint and shared, meaning the tiles are there, very visible and transparent for everybody to see. For all of our key decision makers, our department heads, our vice presidents, our C-suite, to be able to look at and discuss and make the appropriate decisions, again, about the allocation of resources. The data help to inform our daily safety huddles. The data help to inform our discharge meetings. The data help to inform key clinical decisions. The data help to inform our management of patients with certain types of clinical conditions, such as heart failure. It's a great location. It's the envy of other hospitals within the Mount Sinai health system, and even some hospitals from around the area that have started to visit us as well. We're quite proud here at Mount Sinai St. Luke's of that work.